So the talk that I was asked to give today was pretty much physical therapy and Ehlers-Danlos syndrome, but more the perspective of what does it mean, like what is it, how do we do it, why do we do it, and specifically from my perspective. So disclaimers and disclosures, I have nothing to disclose. I will say that the discussions in this are very specifically for general purposes only, especially when it comes to questions. I will not and do not take personal medical treatment plans as options for questions. I cannot and will not do that. I don't have a license in Canada either, so I'm from the US, so just don't ask. The pictures in the presentation, there are quite a few of them, and there are no HIPAA violations. We have forms for all of that. And then the other thing to disclose is also, I'm sorry when I do answer your questions. Unfortunately, the answer to most of your questions will be it depends, because each person is individual and specific, so I'm probably going to annoy a lot of you by not answering your question. So I'll do my best, but I'm sorry. So the objectives to this talk, you guys will get the presentation later, but basically what do PTs treat, what are we doing in what I consider PT. So I'm going to speak a little bit. I am not from Canada, so a lot of your questions might be difficult because I don't speak within your system of how you access your care. So my answers might be different than what you would expect. So it's still general, and there's other people in the room that can answer those questions for you. But the discussion of the difference between structural and functional rehabilitation, because they are very different but coordinated. Also, how to choose a PT, that's a question I get a lot. And also, when to lose a PT. So, decoding different physical therapy terms and also terms to know in general, when to use them and when not to use them. Knowing that EDS is more than just joints, and the whole interconnectivity-ness of it all. It's a very scientific term there for you. So my unique perspective, I am, like they said, I'm a physical therapist from Rhode Island. I was trained, I have a degree in athletic training, sports medicine, what you guys would call an athletic therapist. I also have a degree and a doctorate in physical therapy, but I've done extensive postdoctoral education in osteopathic manual therapy. So in the US, I am not an osteopath. I don't have an osteopathic degree, but I would in Canada not be an osteopath, but what you would consider an osteopath here is how I treat in the US, whereas osteopaths in the US are very different than a true osteopath here. So my perspective is a little bit different than your standard physio treatment process. Also, I am very much a proponent that I don't treat EDS. That's not my job. I treat patients that have connective tissue disorders. I treat patients who happen to have EDS as a diagnosis. Maybe they don't, I don't care. Like somebody said earlier, Dr. Mattel, I think, said earlier, it doesn't matter what the label is. I'm gonna treat you the same way regardless, because I'm gonna treat you as my patient and how you present to me. And what that means is much more important than what label you come to me at. And it's not my job to treat EDS because there is no treatment for it. EDS is a very complicated issue that's why we're having this conference. And so with patients with connective tissue disorders, I would say about 95% of my caseload, I have the ability to see 75 patients a week if I were to max out on one patient at a time. And I would say at least 90% of them have connective tissue disorders, if not more, just because that's what I specialize in at this point. So I had a lot of objectives on my screen, but if there is absolutely one thing that you take away from this lecture, the only thing that I actually care about that you pay attention to is this goal. If nothing else, that you change the perspective of what physical therapy can do for this patient population and what physical therapy means. So PT is not just exercise. PT does not stand for physical torture. It is, I'm sure a lot of you have had very bad experiences in the past. Most of my patients that come in saying, I hate PT, I don't want to do this. Okay, great. And that PT extends far beyond just muscles and joints. So again, from my perspective, from what I'm allowed to speak on, physical therapists, under my scope of practice, we are licensed to treat connective tissue. where Brianne did an amazing job earlier of speaking to what PTs do, and we're movement experts, and we treat the body and how the body moves and how the body's put together. We literally treat connective tissue. That's what we do. So connective tissue, as we learned, is more than just muscles and joints, and it's more than just exercise. So we're not the exercise people. So if that's the case, then what do PTs treat? So PTs treat what we call somatic dysfunction. So soma means body. So we treat problems within the body. We treat altered or impaired function of the components of the somatic system. Very fancy words. We do treat myofascial and skeletal structures, those muscles, joints, but also the related vascular, lymphatic, and neural and lymphatic elements, all made of connective tissue. So that kind of sounds like every patient that I've ever seen that has a connective tissue disorder, since they have problems in all of these systems, could benefit from PT, even if they don't have a joint issue. Just my theory. So connective tissue disorders, we've talked about this, you guys know more than anybody. Connective tissues are made from the building blocks of collagen. Collagen is the structural strength of human tissues, and it's basically the glue that holds us together. So when the building blocks of that tissue are defective at its systemic level or at its structural histological level, it doesn't just lead to one area of weakness, it leads to a systemic weakness and a systemic instability, which is why we've had multiple times before other practitioners and other lectures, and those symptoms that you experience are multifaceted, and it's not just one complaint. And so by the time that you get to somebody that's listening to you, you have so many overlapping symptoms that you're told, yep, it's just stress. That's where pain's coming from. That's it. And it's not the case. You really have a systemic weakness, not just a joint weakness. A joint weakness, you can have an injury at a joint and have joint instability. That doesn't mean that you have EDS. That doesn't mean that you have a connective tissue disorder. So you guys can read it and you'll get a list of it, but the symptoms and symptoms we've already discussed of connective tissue disorders, they pretty much run the gamut of the whole body. So it's more than just joint subluxations and dislocations. They run every system in the body is somehow affected by it, because like we talked about a few slides earlier, they're connective tissue issues, and connective tissue is literally the body. So these are all body-based symptoms. So if it's a cascade. You have a symptom in one area, you're going to probably end up with a symptom somewhere else, which is why by the time that you make a list and they're overlapping, you now have 7 lists of different diagnoses that you think that are all different, but the reason that they're different is that the symptoms for one are the symptoms for 5 others. So a headache is not just a headache, it might be the symptom of 5 other diagnoses. So when I teach my students, when I teach patients, I typically use this analogy. So over here we have a picture of a house. It's very pretty. And this is what your typical house looks like. So if you have your house that looks like this, and then you have your house with EDS, and it looks like this. I don't know about you, but they look exactly the same to me. So when you look at your patient from the outside, they're going to look exactly the same. So your patient with EDS is going to look no different than your patient without EDS. But when you look at your patient with your typical house is built out of strong 2x4s, and there's a plethora of them. They're nice and strong, they're sturdy, and that's where you build your framework and your foundation. But you look at your house with EDS and you look at it closer, and the framework of that system is built out of 2x4s that are riddled with termite damage. And now there's less of those 2x4s than you had in your typical house. So you build this house out of less structure, and the structure that you do have has holes in it. So it's not as strong. So that house stands for a little while, but eventually it starts to collapse. And this is how you all start to feel, even if it may not be how you look on the outside, it's how you feel on the inside, because that's what your body is doing on the inside. From the inside out, you're starting to collapse. And if we don't help you properly take care of that or help instigate some sort of treatment process, this is how you're going to walk into my clinic. So looking at the difference, now this is where I had a great chance to talk earlier about the difference in Canada about osteopathic versus physical therapy. So in my profession, like I said, I'm not an osteopath. I'm not speaking as one. I am a physical therapist from another country, so I don't have any licensure here. So take that with a grain of salt. But no, I want to talk to the difference between structural rehabilitation and functional rehabilitation, because there's different schools of thought within our healthcare community, within what patients have experienced. So the structural rehabilitation is more of that osteopathic, holistic model of a model of recovery, working towards recovery by identifying what the root cause of your dysfunction is. Not just, taking the symptom of the pain away, but identifying why is that symptom occurring and correcting the deficit that caused that problem, not just making the pain better or not just making it stronger because it's weak, but why was it weak to begin with? Was it weak because there was a tear? Was it weak because there was a postural imbalance or a proprioceptive alignment or a motor control issue? What caused it? And then treating it at the cause. Versus a functional rehabilitation approach, which is more of that allopathic MD versus DO, which is your pretty standard approach for what PT schools in the US also treat. We're very much functionally based because PT is all about function, right? No. So that allopathic or compensation-based approach of, well, if you come in with a limp, the PT gives you a cane so you don't limp anymore. Sounds like a really great plan, but now you're stuck with a cane. Like, how about we fix why you have the limp to begin with and treat the cause of that, not just help you not have that symptom anymore. But understanding that you need to have both models working together in order to have a comprehensive plan. You can't have one without the other. You can't just come in and get structural work and then have no functional overlap. And you can't come in for just functional work and figure the structure is just going to fix itself. It doesn't work that way. So with structural manual therapy, feel free to take a picture of the slide. I know you all want to. So these are the words that you want to kind of keep in mind when I go through later to talk about how to pick a good PT. These are all structural manual therapy techniques. So these are all different types of manual therapy techniques that I use in my clinic. This is how I treat my patients. So they're all different, and they're all used in conjunction together. And in order to have a good quality, comprehensive plan of care, your therapist needs to know or understand all of them, not just one. You can't just be a muscle energy person. You can't just be a joint mobilization person. You have to be able to employ all of those techniques because one will feed on the next. You can't pick and choose what you want to do because especially patients with connective tissue issues, you're not coming in with just a shoulder problem. You're coming in with a whole host of things. So you need to have that comprehensive plan. So these are all techniques that I've been trained in that are different than what you would. Some of them are standard for a new grad coming out of school, but a lot of these took a lot of extra training to treat at a higher level of an osteopathic holistic view. So a good quality manual therapist, stretching, in my opinion, hamstring stretching, although billable, is not manual therapy. It's not, and so if that's what your therapist thinks, or that's what the person you're seeing thinks, you might want to reconsider that. It's not that they're doing anything wrong, it's that maybe they just don't know any better and that they need to have a different scope and more experience. And like we talked about earlier, there's functional therapy. Again, very valid and necessary, but needs to be used in conjunction with the structural therapies. And I also have restructured my list a little bit so that balance and proprioceptive training is actually number one on my list because I don't do that standard approach with my patients of start with that individual joint and start to stabilize the strength and then move on and then move on. And then by the time that you're ready to be discharged, we might start working on a little bit of balance and high level activities to send you off back onto the athletic playing field. That is a good progression for that standard orthopedic issue, but no patient with connective tissue disorder is that standard orthopedic person. That's not why you're having therapy usually. You can have an athletic or orthopedic issue, an injury, and it should be treated as such, but also within the confines of you have other things going on. Another one important is postural education, but also neuromuscular re-education, learning how to use your body, just like we had that wonderful lecture earlier. Everything she said, I 100% agree with. I am on board with everything. We are in the same realm. but also, taking into account that all of these things are necessary components of your care, whether or not they're addressed in every single session by your therapist with you, they should be part of your comprehensive plan for yourself at home. So your cardiovascular fitness might not be addressed in the clinic. Maybe that's what you're supposed to be doing at home in between your sessions in order to progress from session to session with your therapist so that you can get your best effective plan of care, because you only have so much time. So what are you doing in between your sessions that's going to give you the best case with that one-on-one time that you're getting? So in the osteopathic realm, we like to talk about structure and function, how they work together. So we say that structure governs function, and then function influences structure. So you could, like I said, you can't have one without the other. Your structure is gonna govern your function. So if, for example, if I tore my bicep muscle and I wasn't able to have that structure in place, I'm not gonna be able to pick up a cup. The structure's been damaged and I can't function. I can't lift anything because there's a structural issue going on. Whereas if I had a job that I was required to lift things all day long, and all I did was this all day, I'd probably end up with some sort of like tendonitis in my elbow, because my function is going to influence what my structure is doing. So understanding the dichotomy between the two is really important for your overall plan of care with your therapist. But one of those treatments that we did earlier that was listed was myofascial release. I do a lot of myofascial release with my patients because it is, fascia is a highly complex web of connective tissue, and like we talked about earlier, PTs treat connective tissue, PTs treat fascia. So fascia is one of those words that you want to store if you haven't heard of it before. And I describe it to patients and students as fascia is the fabric that holds your whole body together. I try to explain it too as like a sweater. So if fascia is like a sweater, it's like a woven network. You actually have one piece of continuous fascia from your head to your toe. You don't have different you have different layers of it, but it's not different structures. It's all one woven layer together. So like a sweater, if you were to get caught in something and it pulls that sweater and you have a big loop hanging out, you can't just like push it back in. It doesn't work that way. The sweater gets pulled in another area, but sometimes if you wiggle that sweater and kind of pull on it from the opposite corner, you can like readjust the tension line and the sweater will readjust. You don't have to throw it out. You don't have to cut that loop and tie it smaller and then your sweater doesn't fit right. Sometimes if you just wiggle it the right way, that sweater will fix itself and then everything will work better. Well, that's how the body works. Sometimes there's a pull or a tear or a strain on one area, and if you attack just that area and keep poking at it, it doesn't really do you any good. But if you treat something further away on the other side, you can adjust the tension lines and you can adjust the fascial tension so that area that's symptomatic might get better, even if you can't address it that day. So why does it work? So this is my little red structure is my muscle. So my muscle says, the other one is a section of the spinal cord. My muscle says to my spinal cord, hey, this is what's going on with me. This is what we call sensory afferent input in. So my muscle sends input into my spinal cord saying, all right, I want to do something. Spinal cord says, okay, well, contract and move. That's how the body works, right? So what happens when there's an injury? So just like that bicep tear we talked about, or that injury in your arm, it says, there's a problem here. That hurts a lot. So then your bicep sends that info in and it says, that really hurts a lot. So your spinal cord says, your nervous system says, okay, well, if you're hurt, then do something about it. Maybe you should shorten. Maybe there's an injury there. So then it shortens that muscle and it tightens on that nerve, which then says, hey, you just pinched me, but I thought I was hurt. And so it says, okay, now it's louder. It says, okay, that really, really hurt, and now I'm in pain. So your body says, well, then you really must be injured. Why don't you shorten and try and protect yourself, and let's shorten over that area again, and you pinch that same area again. And that's just going to keep going and going and going until you somehow alter that cycle. That cycle needs to be, so you have pain, which puts you in spasm. Then the spasm causes you pain, and then the spasm causes pain, and you keep going until somehow that changes. Well, how do you get it to change? you have to input new input into the system, and that's where physical therapy comes in. That's where some of your modalities for other things, your pain medication, whatever it may be. You somehow have to disrupt that cycle, but also being important that if you don't listen to it, nobody really cares in their grand scheme about their arm. You can get through your day with a sore bicep, but if you stop listening to your bicep muscle, and it says, okay, well, now you didn't listen to me, and I'm having arm pain, I'm having shoulder pain. All right, if you didn't listen to your arm, I'm going to start to send, so there's a sensory component out of every spinal segment, there's a motor component, but there's also what we call an autonomic component out of every spinal segment. So it says, okay, well, if you didn't listen to your shoulder, which I thought you were injured there, but you're not going to listen to that, I'm going to send it to something that might be a little bit more important, and maybe you'll listen if I start to give you like heart palpitations. Maybe you're going to think you're having a heart attack. So maybe you might listen that you have a problem and that you should address this, because now it's sending you symptoms elsewhere. Because at that same nerve root level, it's going to send it to a different organ system. And maybe you'll pay attention to something more important, because then that sends it back in and says, hey, I think we have a problem here. And now you have another layer of symptoms saying, all right, now I have cardiac symptoms and I have shoulder symptoms. So then eventually, you let this go on a lot, and then eventually maybe you end up with a cardiologist, and but there's nothing wrong with your heart, because it wasn't a heart problem to begin with, it was a shoulder problem. Or was it a heart problem that then became a shoulder pain, which is, a classic indicator. So, identifying what that root cause is really important. And in this population, there's so much overlap with all the different conditions that's where this becomes tricky. So having a practitioner that's going to really look at you comprehensively and holistically, and not just treat the symptom that you're complaining about, because maybe you do legitimately have shoulder pain, and maybe it is a shoulder issue, but maybe it's not. And looking at the difference between the two is really at the root cause of what osteopathy and the osteopathic model of treatment is really about. So when those things happen, we talked about that pain spasm cycle. We have on one side over here, we have this is normal alignment. So everything's hunky-dory, but then over here, well, maybe I turned the wrong way, or I turned too quickly, and those facet joints, which are, by the way, these on the side, they got locked or closed because they're in spasm, and now they're causing us they're causing pain at one specific spinal segment, which is causing back pain or rib pain or something at a specific segment, and that's causing a rotation, which is now you're like standing kind of crooked because your body's locked. And then you go through your day, and now your posture's off, and like we talked about earlier, like standing in a bad posture long enough, you're probably going to end up with a problem, and then you develop something else, and it becomes a progressive issue from there. So we treat the spine and ribs in my clinic, or we treat them every day. That's the baseline core of the structural components of making sure that your structure's in good alignment so that you can function properly. Because you can't do exercises effectively if you're going to stand like this. I don't let my patients do good standing exercises if they can't stand up. It's not what happens. I have to treat the cause of what's happening versus just giving you that functional strengthening outcome. So let's talk a little bit about rib subluxations. So a lot of times I have patients that don't even know that this is a thing. I have doctors that daily argue with me that this is not a thing. So a lot of times patients come in complaining of back pain. It's a very common complaint. Patients with connective tissue disorders, patients without connective tissue disorders, which is actually a really important thing to understand. Just because you have a rib out of alignment or there's a rib subluxation doesn't mean that you have EDS. It's not always an EDS thing. Everybody gets these. Believe it or not, ribs do move. I've been fought tooth and nail by a lot of practitioners. Ribs move. They move a lot on a daily basis. Otherwise, you wouldn't breathe. They don't move a lot physically. Wow, I'm really good. Or bad. Ribs, they move all day long. Otherwise, you wouldn't breathe, you wouldn't function, and the rest of your systems would start to shut down. Now, the movement is small, but it's significant. So if we look at the anatomy here for the rib, so these are the ligaments that help hold the rib in place. So as we know, patients with EDS or connective tissue disorders, they have deficits in their ligaments because they're made out of connective tissue. So that collagen is weak, so they have a propensity to increase that mobility in that rib, so there's a little bit more movement available than somebody else. And if you don't have a strong structure behind that, muscularly, those ligaments might cause a little bit of movement. And unfortunately, we're going to talk about the clinical correlation. There's important stuff near the ribs, right? Ribs kind of, they protect some important stuff. So when you have a rib subluxation, typically a lot of times they'll be at what we call the costovertebral junction, so where the rib meets the vertebra. Very fancy term. Rib part of the word, body of the vertebrae. So this is where the rib lies. So this part over here is the spine. Look at all of those ligaments. Look how many there are. So we talked about there being weakness or a deficit there. And this right here, this yellow line, this is your sympathetic ganglion. So the sympathetic division of your autonomic nervous system. So you have two sides. You have your nervous system. We have your central nervous system, brain and spinal cord. We have your peripheral nervous system, everything that runs down your arms and legs. And then we have that whole other system of your autonomic nervous system, which you guys pretty much know because when it goes haywire, there's a problem with it. We call it dysautonomia. So that's a problem with that autonomic function. So those are divided into two categories: your sympathetic system, which is your fight or flight reflexes, and then your parasympathetic system, which is your rest and digest reflexes. So right through the middle of your body, what we call your thoracolumbar, your kind of midsection here, which is really important for core posture and strength, that's where all of your sympathetic system is housed. Those are all your fight or flight reflexes. So if you have a rib that's moved, even just a little bit, even a millimeter, it can push on that nerve, which is then potentially going to set you up for a dysautonomic reaction, which is then going to give you symptoms of dysautonomia. And then you come into the clinic with huge flare-up of your POTS, or your symptoms of dysautonomia, and back pain. And you don't want to exercise that day, or you can't exercise that day because your system is dysregulated. And so a lot of times you don't, because your other symptoms are overriding that. But if there's something that we can do to help reduce the rib subluxation or the structural issue, maybe you're not having as many dysautonomia symptoms as you thought. Maybe they were being propagated from a structural issue, or maybe the POTS or the dysautonomia was actually causing that to be the issue. So that's where you have to balance out what's happening. So looking at that structure versus function relationship is going to be really important. And so when the rib is the problem, or the spine is the problem, and the muscles around it are causing the pinch on the autonomic nerve, that's going to set off the dysautonomia, which is more of a visceral dysfunction, the guts and the organs and all that kind of stuff. So that's what we call a somatovisceral dysfunction. So that is a very PT thing that we treat. That's, those are the words that we use, but I'm not treating your stomach. But if you have a dysfunction at T6 of the spine facets, or if you have a dysfunction of your rib number 6, and I can treat that, and then your stomach pain happens to go away, or your gastroparesis gets better that day, did I treat your gastroparesis? No, I didn't treat your stomach, but because we talked about everything's made out of connective tissue, if I treat the connective tissue around your stomach, then your stomach pain happens to get better, great. If not, then maybe your stomach, we need to look into more of what's going on there. That's not my scope, and that's when we need that team approach, and I need to refer out. So, like we talked about before, dysautonomia. Dysautonomia is really a blanket term for the malfunction of the autonomic nervous system, and I'm lucky enough I actually sit on the board of directors for the Dysautonomia Support Network, so I treat this a lot in my patient population, but I also deal with it a lot in one of the charities that I work with. So your autonomic nervous system is one that's highly undervalued and under-recognized in all of your practitioners. Across the board, I feel like none of us really know how it works well and don't know how to incorporate it unless you're going to somebody specifically for that expertise. They don't respect and integrate the autonomic function into their daily treatments, where it really is a huge component. If you're going in for any sort of core stability work or anything that deals with your trunk and lumbar spine, that's where your entire autonomic nervous system is being housed. So of course it's going to have some sort of influence on it, right? So dysautonomia is basically when the ANS, or the autonomic nervous system, goes haywire, and since, like we talked about, the EDS affects every single system, and your autonomic nervous system affects every single system, you're probably going to have a lot of overlap. So earlier, we were talking a lot about some of the research that's coming out, and it's really important that you are getting the best evidence-based practice. That's what we want to strive for. And, that's what we strive for in the US, that's what you guys are striving for here. We all want to provide the best evidence-based practice. And one of my mentors actually did a research study kind of on his own to see how many of our students coming out of school who have doctoral level educations even know what the definition of evidence-based practice is, or even the other clinicians. And more than 50% to 75% of those people surveyed every single time that we would ask that question didn't know. So, yeah. Actually, most people in the room probably don't know that evidence-based practice, the definition of it is not the research. That's 1/3 of the answer. So I actually found a really great article. If you Google evidence-based practice, the first article that pops up is actually somebody from Ontario. So evidence-based practice is actually a 3-tiered model of combining the overlap of the best research available, the best scientific peer-reviewed research, a best level of clinical research available, the clinical expertise of the practitioner involved, and patient preference. And where all 3 of those overlap, that's where your evidence-based practice lies. That's where the best practice is. If you, just like we talked about earlier, that upright MRI might be the best practice available for you, but if you have a practitioner that can't read it, then what good is it? If you have a PT and I'm telling you that this is the best way to treat your patient, I'm telling you that you really need to know a lot about muscle energy and myofascial release and cranial therapy and vestibular therapy and balance and proprioception, but your practitioner doesn't know anything about muscle energy and myofascial release, then maybe they shouldn't be trying to do it. If they don't know, if they weren't trained in how to do it and they have no expertise in it whatsoever, then they shouldn't be the ones doing that. Just because it might be the best thing to do, if they have no good experience in it, they're not the best person to do it for you. And then you as a patient, your values of what you consider important. I have patients that their pain is actually not important to them. They don't care. They don't hold their pain levels as important indicators of how well they're doing. They accept that their pain level of their hip is a 5 that day, and as long as it's their normal, they live at a 5, and they don't consider that, a detriment to them moving forward with their activity. And if I've determined that there's nothing structurally going on that's going to inhibit or make them worse, if they're willing to tolerate what they perceive as a 5 out of 10, then that's okay, because that's their perspective of what's going on. Whereas I have patients that consider a 2 out of 10 like the worst thing in the world. And if you can't function with a 2 out of 10 pain, I'm not going to push you through that. I am not a proponent of no pain, no gain. So if you can't function with a 2 out of 10, I'm not going to make you do something that's going to increase that level. Do I think a 2 out of 10 is bad? No. But if that patient's perception is that 2 out of 10 is the end of the world, then that's the level that we need to, kind of start at and support them at that level, because I can't get anything done functionally if I can't get them to override that. And there could be a number of reasons why that's the case. But yeah, evidence-based practice is not just about the research. That is 1/3 of the answer. And so feel free to look it up. There's the definition of it. Like I said, the first person that you'll find is a Canadian author. And important to note that EDS, patients with EDS are very complicated, and it is very much a team approach. Physical therapy, while important, I'm not actually the most important answer. I'm not the answer. I'm part of the team, and the team approach is really what's going to get patients better. Physical therapists, or physios in this country, or however you want to term who you're seeing based on who you are seeing. I am a physical therapist, so I deal with PT issues. I'm not a neurosurgeon, so I don't deal with neurosurgical issues. I deal with patients who have just come out of neurosurgery. I deal with patients who have neurosurgical complications, but I am looking at them as a physical therapist, and I'm looking at them as how to treat them, within my scope of practice. And everybody has an important role to play at that table, but you also have a very important role to play at that table, that you are an important member of your own team. You need to advocate for yourself. It's very important that I tell patients all the time, I can't fix you because you're not broken. So when you come to me, you might have a lot of things going on, but you're not broken. I can't fix you. Therefore, that's not really helpful. You need to come at it from a very holistic standpoint of you can improve and you can get better. Just important to note that you want to make sure that you're using the correct words and terminology. It's going to be helpful for you going forward, knowing, like I said, what words to use when you're going to pick a PT, knowing what they can do and what they can't do, but also knowing what skills and treatments are required for you. But more important, the definition or difference between what a dislocation is and a subluxation. Please don't walk into most clinics telling people that you dislocated your hip today and that you're having a lot of hip pain, because the likelihood is you probably don't, if you walked into the clinic, you probably don't have a dislocated hip. And the more that you say things like that, now it just might be a misconception, but the more that you tell people that, or you tell the orthopedist, oh, I dislocated my hip yesterday, it's highly unlikely that that was the case, because then you're going to start, they're not going to believe you anymore because you're using the wrong word. You probably didn't dislocate it because it was subluxed or it was out of alignment, but it probably wasn't dislocated. So understanding the difference of what's going on in your body is really going to help you become a better advocate for yourself. So general PT guidelines, you guys can read these. I have patients come all the time that want to tell me, I want a PT that knows all about EDS. Great, you're not going to find one. If you do, I'd like to know who they are, because I know a lot, but I don't know all of it, and your best bet is really to find somebody that's going to be willing to go on the journey with you. It's not about finding somebody who knows everything now, it's about somebody who's willing to learn everything about you, because a lot of what I've learned about patients with EDS, I've learned about because I have patients with EDS, and I've learned about those patients, and everything that happens and goes wrong with them, I find out what's going on because it's going wrong with them, and then we learn together on the journey. It's been a very long journey for many of us, and so it's been a good 8 years of me learning, because I've been in practice for about 8 years now, and that's all I see. A high-level knowledge of manual therapy and a utilization of those techniques, like we talked about, kind of the mantra of going low and slow. So knowing that you have to go with these patients, on just my own clinical experience, nothing publishable research-wise, I tend to quadruple timeframes. So if your typical patient's going to take 1 day to get better, I tell my patients it's going to take 4 days. It just tends to be around a good average for me of how it's worked out. So if the average patient can do 1 rep, or can do 10 reps, my patient can do a fourth of that the first day. So also finding somebody that, like I said, that you're comfortable working with along the journey, because it's not about finding somebody who has all the answers, it's about somebody who's willing to find the answers out with you and for you as you're going, because you are the patient. They're not treating EDS. If they are, they're lying to you. They're not treating EDS, they're treating you, and you happen to have a diagnosis of EDS. And that's more important. If they don't understand that, and if that's not how they're looking at you, then you need to find somebody else. And that PT is very specific to each person or situation. So how to choose a PT? Like I said, you want to find somebody that's going to go on that journey with you. That's a very nice picture. It's a pretty picture. It's a nice straight line. You're going to go on that journey together. Sounds great, right? Well, the reality is this is actually where you're going on that journey. So you need to find a PT or somebody that's willing to commit to this road with you, because it's not going to be that nice, pretty, flat journey with the sunset. It's going to be this road that's broken and turning and up and down, and you're going to get lost on that road together, and you need somebody that's willing to commit to that journey and go and explore down the rabbit hole with you. But also very important to, I've had, to have this discussion with other people, when to know when to lose a PT or any practitioner, any doctor, that, some people stay out of loyalty because they've been with somebody for so long that they don't want to stop seeing them, but they're not getting any better, or that they're getting hurt when they go to sessions. And it's not that that practitioner is doing anything malicious to them. it's that they might not be the right person for you. And don't just stay because you feel like you have to. There are other people out there, and that person might not know that you're unhappy. You need to have that open dialogue with them. But are your needs as a patient being met? And if they're not, then maybe you need to go somewhere else. If you've ever been told that you have plateaued, this is, again, different with your system than ours, but I refused. I have never actually used that in my documentation. I will never tell a patient that they have plateaued and that they're not getting better or that they won't get better. Because I was trained by a very, very smart man. My mentor told me something that was very harsh to hear, but he said, patients don't plateau, therapists plateau. So if your patient isn't getting better, it's not their fault, it's yours. You have stopped progressing, and maybe you're not the right person for them. Either you're not the right person and you need to refer them to somebody with more expertise, or you're not thinking enough and you're not helping them, or maybe you're not the right clinician. So I have a patient that's going to come up in some slides, and I promised her when we started that we would work on this journey together, and I would let her know and be very honest when we transitioned from the point where she was with whatever area in still what we called what we're determining as a rehabable position. So when she was no longer rehabable, and when I felt like I had failed, then we would call Dr. Henderson, and at that point we would let him take over, but we would try to prevent that time gap of when she needed that surgical intervention because it was still a rehabable condition. And when it wasn't that any longer, we would say, all right, it's no longer my job, let's put you to the next level and where you need to be. But if you're getting injured in therapy consistently, please seek treatment elsewhere. So, proprioception, again, this patient has signed off all disclosure forms. How much time do I have left?
Oh, sorry, you have about just under 8 minutes.
Okay. So this patient, I wanted to show some of her pictures of her treatments. So I start with proprioception on everybody too. A lot of my patients get self-corrections for home. They get a lot of home exercise programs, and I use all treatment modalities. I am not picky. I'm very picky actually. I don't use a lot of modalities. I don't use a lot of machine-based modalities. I use manual therapy and exercise and things like that. But with these pictures, especially the first two up here, I want you to kind of look at them. These look like very high-level athletic, activities. She's actually one of my most complex, medically fragile patients, but these are some of her basic treatments. She does a lot of stuff at home, but these are some of the things that we've done in the clinic with her. And so these two pictures over here, which one of these two pictures do you think came first? The top one or the bottom one? Yeah, so she was actually in a much stronger, state in the top picture than she was in the bottom picture. Medically, she was more stable here than she was here. So this is actually a lower level function than this. But it looks weird because she's got all this extra bracing. This was post-op, or this was her first day allowed to being able to walk again after a surgery. This picture was taken a year before something happened. So she was doing all this activity, and then she had to relearn how to walk again. Now, this is not actually the reason that we did this was not meant as a strengthening exercise, even though that's what it looks like. This was done because she has no idea where her feet are in space. So the elastic actually just provided her the compression to figure out where her legs are, and she's a genius. I love a lot of the things she's come up with. She wears an anklet that she designed herself on one of her feet because she can't feel her leg. So she couldn't remember to pick it up when she was walking, so she put an anklet on her leg so she could hear it, so she remembers to pick her foot up. She did it, I didn't. I love that technique. She came up with it herself. So it looks like from the picture that she's doing better down on the bottom picture than she is at the top, but she's actually stronger medically and structurally at the top when she looks worse off. Same thing here. These are all, hopefully these are happy adult physio ball pictures. So these are all proprioceptive issues. These are not, so we're working on more than one thing. So this one activity is working on her core stability, her hip stability, her strengthening, her posture, her balance, her visual perception. But which one of these two pictures is more advanced? The one where she's catching a ball or the one where she's standing by herself? No. Standing by herself, she's actually doing a much higher level, even though she's standing on her own, but I'm no longer holding on to her. But in that picture, you also notice that she has a VOG mask on. So medically, she was more compromised in this picture than she was in one of the other pictures, but structurally, she's actually stronger in the picture that makes it look like she's doing a lower level function. And so again, just some specific things. So I make things up as I go along. So one day we have to treat her upside down this way because of high pressure headaches or whatever the issues might be. Her feet might have to be up in the air. And then some days her tube feeds have to be on 24/7, so we have to treat her with her head up, and we have to treat the other way. So I treat my patients based on how they present in the clinic that day. And then these pictures over here look like things have gone wrong, but these are medical complications with her. They have nothing to do with her PT treatment. So these are things that you have to deal with within that journey. So it's always an upward journey. So she's doing better today than she was when I first started seeing her. But along the way, it's not been a flat journey. It's been a very convoluted, complicated journey. And then this picture in the middle is one of our latest. So this is actually when I lost my mouse. There it is. She's the strongest that she's been, even though she looks like she's just been run over by a bus. So this is her first day that I allowed her to stand up after one of her latest surgeries. And so we actually, a while ago, started taking photos because we've had that up and down journey for so long that we wanted to have a chronology for her of what was going on. So we started taking like monthly photos when we do her monthly progress notes for the insurance company. And so they're a little, if you look at them, it shows that kind of journey. So the first one up at the very top is before she started seeing me, and what she looked like and all of her bracing, and then all of the things that we have adapted or changed in her plan. Her bracing has changed, her medical complications have been going up and down. Sometimes she has a mask on, sometimes she doesn't. So all the way down to this bottom, so her progress went this way. And they were monthly for a while, and then things got in the way, and then they stopped being monthly. And there was we referred back to the surgeon again. Then there was like a 2-month gap in her care because she was in the hospital. And then she came back like this, and then we did more stuff. I moved to a different clinic. And now she's here, and this was our last updated photo, where she's actually stronger here than she was here when she looks happy and strong and there's no bracing on her. And she's here, she's actually stronger medically and structurally than she was in prior photos. So really understanding your patient's journey and where they are and how to help them along the gamut, and that it's not a one-time thing. And using every available treatment modality for them at their level, but I don't care what it's called. I treat the patient that's in front of me with whatever treatment modality they need that day. It's not a cookie cutter approach. So, anybody have any questions?